just skip the bit about feeding back from each group, because we're in danger of getting very behind, and I think people can't really do justice in 1 minute to the discussion, but we have recorded all of those, the notes have been taken from all the discussions, and they will be central to what will feed back to the Department of Health on further research priorities and strategies. So, and we'll also have a little bit of a final Q&A, final comments after Viral's talk. So if there's anything from the group discussions that you would really like to share with the whole group, you can maybe do so at that point. So it's great to be able to introduce Viral, who is fairly central NHS England person in the work for the Mental Health Act, for the independent review of the Mental Health Act, and is going to give us a policy maker's perspective on the way forward. Thank you very much. Yeah, somebody...
Thanks, Sonia, and sorry that I couldn't be here for the rest of the day. Doing quite a lot of work prepping for the start of the financial year 1920, which is in 1 week's time. So that's why I couldn't make the whole day, I'm afraid. And I hope I'm not going to kind of duplicate too much or go over the same grounds that other people have, although I'm sure pretty much everything that I'm going to say will have been talked about in some form, but not necessarily from my perspective. And I was following a bit of the discussion earlier, so I'm pretty sure that is the case. So I'm just going to go through kind of 4 different bits. The first one I won't spend very long on, telling you who I am and kind of why I'm here. The second one is, from my perspective, working at NHS England in the adult mental health policy team, what were the most pertinent issues from the review. Thirdly, the long-term plan for mental health and what are the kind of relevant areas to the Mental Health Act. There's a bit of a hint, pretty much all of them. And fourth is my reflections on research needs, so building a little bit on the conversation we just had upstairs on the kind of professional's perspective. So who am I? Good question. So I work in the NHS England Adult Mental Health team. I've been there since January 2016. Prior to that, I worked at the Department of Health on the Mental Health Crisis Care Concordat with Matthew over there, as well as the Mental Health Act Code of Practice and the 2015 revisions. And also worked with Matthew on the review of sections 135 and 136 of the Mental Health Act. So the good thing is, when I moved to my new role at NHS England, I was able to kind of take some Mental Health Act knowledge across, which was obviously very needed as we were thinking about things like how had the 2015 code been implemented, or in some cases not been implemented, and also to have a bit of continuity around the work, the policy work. Ministers had kind of commissioned around crisis care, but also trying to actually make it happen on the ground and support local systems to make a change. So I also sat on the independent review of the Mental Health Act's working group, and one of my key tasks that I was given, not only by Simon Wesley but by my own bosses back at NHS England, was, can you do what you can to ensure there's some alignment and consistency between what the review of the Mental Health Act says and what the long-term plan is going to say or intends to say around mental health. It's not always easy for a number of reasons, mainly because the drivers are different. So Simon Stevens had said, we want to do a long-term plan, whereas for the independent review of the Mental Health Act, it was the Prime Minister who said, I want Simon Wesley to lead a review of the Mental Health Act. Now, a lot of the time, similar people are involved, but because there are different kind of political drivers, different policy drivers, it's not always easy to kind of line up your ducks in a row, especially when it's two extremely kind of high-profile, very intelligent people leading the bits of work. So I think for us the biggest challenge was where are the natural interfaces, where are the natural kind of areas of interest overlapping? And I've just picked out a few examples here. So one was around ambulances. So through our engagement on the long-term plan, it became very clear that the ambulance response to people in mental health crisis needs to improve. We kind of knew that already because we've been doing work on crisis care in the Department of Health, but also in NHS England for a number of years. And at the same time, Simon Wesley was kind of saying, okay, as part of the changes around Section 136, we should definitely be saying something around needing to reduce radically the use of police vehicles for people who are detained under Section 136 and taken to a place of safety or 136 suite. So that was an obvious area where we said, okay, the Mental Health Act review is talking about the need to improve 136 related conveyance. We know more widely that we want to improve the mental health crisis response of the ambulance service. There's an area we can agree on. So 136 is a kind of very small part of overall mental health related kind of demand that ambulance services see, but it's a very important one. So that was an obvious area. Two of the areas where Simon Wesley made a big public call for investment, luckily, as you would expect, these were two of the areas that formed the kind of backbone of our proposals around care for children and young people and for adults and older adults as well. And that's crisis care and community care. So I think that was, again, an opportunity for the review and Simon and his team to kind of lay out what they wanted to see, a kind of a game-changing investment in community mental health services and in crisis services as well. And that was what the long-term plan was able to respond to, and I'll talk about that in a bit more detail in a second. Another major one was making acute inpatient care more therapeutic. So part of this was around what happens when you're in hospital, who are the people that see you when you're in hospital, but also the environment you're in, the physical environment you're in. And people might recall that one of the big headlines on the day after the review was launched, or on the day of the launch itself rather, was Simon Wesley's public call for a major capital investment to revamp and modernise the mental health estate, to move away from this idea of kind of having Victorian corridors with no line of sight, very unsafe, and kind of buildings crumbling and falling apart, things like dormitories, mixed sex wards, some quite basic things about what the environment should be when someone goes into hospital. So obviously I mentioned the kind of the choreography required, because what the review looked at was not only the letter of the law, but it was also policy, it was practice, and it was implementation. I think that was very clear. So as much as you kind of make the law a perfect law, which is almost impossible anyway, it doesn't really matter if it's not implemented and not backed up by the policy and the practice that's required to follow up. I've talked about this a little bit just now. One of my favourite subjects, as Matthew and Richard know by this point, is data black holes. So national data is critical to enable us to kind of make good policy, or to at least know what's going on within the system, but we've still got some major issues. So the National Mental Health Services data set, which is for all kind of secondary mental health services, underwent a transition a few years ago, which means that the Mental Health Act data is still very new, and it's not at the completeness, as we say, i.e. the quality of the data is not quite 100% yet. So we need to get to that point so we understand actually genuinely what's happening, and then can have a baseline to compare for future years. Just one other thing that I would pick out there is data from approved mental health professionals. There isn't a national data set for approved mental health professionals. So these are the people who ultimately make the decisions about who is detained and why, yet we aren't collecting data from them at the moment. A couple of other things that I found very useful and very interesting, as well as challenging, was the discussion around why do rates appear to be rising. I know that's the kind of central theme of the day. So if we have a lack of formal evidence, what do we need to do about this? And I'm hoping that the outputs of the entirety of today's discussion will help that. We had a lot of conversations about what if we start from a very logical, basic point of view. If you provide responsive, proactive, high-quality care in the community, does that stop people from getting more ill? and deteriorating to the point of needing detention under the Act? The answer is probably yes, but we don't know. So I think that kind of debate will go on for a long time, and I'm hoping there are things we can do to bring the different challenges together. Risk, constant theme. There are some very strong points in the report about the need to bring different sectors together, including the chief coroner, but also local coroners, given the variation in practice, to understand, what are the drivers that drive this idea of professionals being risk averse, whether or not that's true, whether or not you're talking about police officers, whether you're talking about AMPs, whether you're talking about doctors themselves. There does need to be a wider discussion about that, because if there is a consensus view that approaches to risk are driving professional behaviours in different spheres, then we do need to really crack through that, and it's not an easy thing to talk about. Workforce, I'm just going to pick up one thing from there. So we had a conversation within the review working group around the links between staff experience and the quality of care in acute physical health settings. And this for me is something I think is really interesting, because it's not really been explored properly in mental health care. And a lot of the time the automatic assumption is that, because of resource constraints, but also because of attitudes and behaviours, that people who are detained in inpatient settings do not get high quality care. So I think there's a fundamental question to ask about, if we're able to take care of our staff, if trusts are able to take care of our staff, if they're supported by a kind of national policy, can we help them to have a better experience of their work, which then has a positive impact on the care that they are able to deliver to patients? I think it's definitely worth something that's exploring. Digital, just one very quick example up there, is about this idea, and it struck me very heavily when Steve Gilbert, one of the vice chairs, told us a bit of an anecdote. So he goes into hospital for the first time, and he's given a kind of floppy folder with some old photocopier paper, which kind of sets out his rights and key information about the Act. Now, I've got a serious problem with that when we're detaining people using the power of the law. Why can't we do something a bit better and a bit more modern? Like, for example, providing people with a small tablet, or putting them inside a room where there's some sort of animation that can actually give them information, advice, support as they need it in a much more kind of user-friendly way, instead of chucking a bit of a ring binder at someone and ticking a box saying they now know what their rights are. So I don't think that's right. So I'm not going to go through everything, but the long-term plan for adult mental health contains a lot of things that are relevant to what I mentioned in terms of crisis care, acute care, suicide prevention, and community care, particularly for people with severe mental illnesses. So the commitments are around 24/7 access to crisis services, improvements in NHS 111 and the ambulance service, continuing the expansion of acute hospital liaison mental health services, particularly in A&E. I think this is a really interesting one, a new area, again, non-medical alternatives to admissions and to crisis response. The clinical review of standards that was published, I think it was a couple of weeks ago now, talked about the introduction of waiting times for emergency mental health services. The move to make inpatient wards more therapeutic through kind of increasing the skill mix of staff working on wards. On the community side, the long-term plan talks about creating new models of integrated primary and community care that includes various different kind of key components of a new offer. So genuine access to psychological therapies for people with severe mental illnesses, improved physical health care, care for coexisting substance use, employment support, medicines management, and also talks about testing 4-week waiting times as part of testing the new model of care. Also focus on some specific areas where we know the treatment gap is high, especially for areas where the kind of condition is associated with high mortality rates and high kind of morbidity as well. So community mental health rehabilitation pathways, personality disorder, adult eating disorders, and increasing and building on the progress made to date around early intervention in psychosis. And there's also specific things around extending the current National Suicide Prevention and Reduction Programme, as well as kind of embedding this within the new Mental Health Safety Improvement Programme and the new wider patient safety strategy for the NHS. So I've mentioned most of these. I think that just to touch upon the ambulance side and the non-medical side. So on the ambulance side, we talked specifically about vehicles, and that's subject to the capital funding settlement through this summer's spending review with the government. But it's also about the staffing element. So there's no point kind of having a load of new vehicles if we don't have people with expertise or a higher level of expertise than the current workforce has around mental health. So it's about increasing the mental health competency of ambulance staff, as well as focusing on the kind of triage element in the 111 and 999 control rooms. So I've talked about non-medical alternatives. So we're thinking about, there's been quite an explosion of kind of innovative new models, predominantly led by the third sector, formally commissioned by CCGs or local authorities, or a partnership of both. And those are things like crisis cafes or sanctuaries. And if you actually look at some of the evidence that's emerging of probably kind of varying quality, but certainly anecdotal evidence that comes through, is that patient satisfaction and patient experience is extremely high for these services as compared to kind of traditional conventional services. I mentioned the kind of need to make inpatient care more therapeutic. So it's particularly, as I said, looking at the skill mix of staff working on wards. So thinking about the potential roles for a great number of occupational therapists, psychologists, physiotherapists, and peer support workers as well. So it's moving away from this idea of a very kind of pure clinical model and understanding what might actually help people when they go to hospital. And I think it's also important to note that the long-term plan talks about reducing length of stay, and it's important that that's not seen in isolation. So it's not just about reducing length of stay for the sake of it. It's about understanding that actually in this country we have among the highest lengths of stay in the whole of Europe, which is quite interesting given that we're supposed to have, in theory, a fairly developed model of community-based care. So what is happening in the areas where there do seem to be higher bottlenecks? Is it because of issues to do with social care? Is it to do with issues to do with housing, which a lot of the time it is? Or is it because the offer of community-based kind of care, both from the NHS side and beyond, is not there? So I won't talk about this because it kind of, the slides can be circulated. They're all kind of publicly readable and accessible.
3 or 4 minutes.
And it just goes on into a little bit more detail about the new primary and community-based offer. I think it's really important to note that the idea is that the model is inclusive. So we want to start from a fundamental kind of point of inclusivity, not exclusivity, which we see a lot at the moment. So that's going to be a real challenge to services. There's a lot in there about workforce competence and confidence. There's also a lot in there about culture and challenging the culture of what we see all too often is people falling through the gaps between services, people not meeting what are often arbitrary thresholds, but have grown because of things like resource constraints and because services have tried to find ways to evolve to manage what a lot of the time it feels like a kind of overwhelming surge of demand that never really goes away. So I think that's a huge challenge to services, but I think we're going to set the ambition and the vision straight up and genuinely support systems with investment, but also kind of implementation support to make that happen. So I can't remember how many slides I've got left. I think it's about 3 with reflections on research needs. I hope that's okay. So I mentioned the need for systematic data collection. I think it's really important to not just focus on the NHS here. For example, we've got some good annual data from the Home Office now and their annual data requirement about use of Section 136, but the problem is it's only annual and it's published 6 months after the end of the financial year, so that gives us, there's a time lag and a limit on its usefulness as a result. And as I say, I sat on the working group looking at addressing rising detention rates, so that was obviously where I was thinking, okay, we might have some ideas and some theories around what might work and what might not, but if we don't have the formal data and we don't have the formal evidence to support it, then we're going to have to kind of, I guess, feel around in the dark a little bit, which is not ideal. So I've just picked out in italics some of the content of the supporting documentation that was published alongside the review itself, or with a little bit of a delay actually. And these are some of the bits that came out of our working group specifically. So improved research and evaluation is needed to inform the design, commissioning and funding of services and interventions to tackle rising rates of detention, part of the reason we are here. For me, this is one of the most important things, is that evaluations need to look at a broad range of outcomes and benefits, including the views and experiences of service users, families and carers. So we're talking about going beyond the traditional reliance on RCTs, and I think it's also genuinely about thinking about the views of and experiences of service users, families and carers as genuine research. It's not kind of an optional added nice extra. This is an area where we need that information because we don't have the information from anywhere else. So it's important in and of itself, but I think it's really critical now that we kind of get that in a way that's systematic and used for improvement as well as genuine research needs. So this was another point around the need for a bit more flexibility in how information is collected. So this was, I guess, partially a response to the point about RCTs taking too long. And something about sharing iterative findings between researchers and professionals on a much more kind of dynamic, as close to possible real-time basis. So that's not just about informing the research, but that's also informing kind of local quality improvement approaches, because we do have an issue when it comes to research around the lag. So this talks about a new focus on user and carer-led research, and as I say, genuinely kind of embracing the richness of experiential information. And I know that that's obviously not always kind of easy. We had some long discussions around the fact that that has to be done in a kind of respectful and safe way, because not everyone wants to share their experiences, and people who do, sometimes they are obviously very traumatic experiences. But I do think it's very important that we, as professionals, that we kind of draw on the information not only of practitioners at a local level, and I would include local authority professionals as well as police officers and ambulance staff, etc., as well as the kind of more traditional side of doctors and nurses. And that's it really, and I think that's probably an apt point to end.
Okay, thank you very much. It says closing reflections, which I take as spare time in case it's running over, so I'm not going to do a great deal of reflecting at this point. But we have got time for some final questions and comments, if people have any for Viral or in relation to anything else that's been said today.
I've got one for Viral. I really appreciate what you said about improving the offer from emergency services in 111, but they use a system called the Directory of Services, people are aware, and a lot of mental health services, especially the smaller ones, don't actually engage very well with that. So unless the paramedic has got local knowledge, they won't know those alternatives.
Yeah.
And then at that point, if they don't know about them, or they can do it in A&E or somewhere else. How do you think that could be addressed, or does MHSE have the stuff?
Yeah, so I mean, I think the most important thing to say is there's massive variation across the country. I mean, I could say that in response to basically every question, but I think so commissioners are ultimately responsible for keeping the Directory of Services up to date. So if you're a mental health commissioner, for example, and you want to improve your crisis pathway, you can commission these alternatives, but they're not going to be useful unless you commission these alternatives and also ensure that the Directory of Services is up to date with those new kind of services or new alternatives. Because if the point of you commissioning those alternatives is to help, in theory, improve patient care but also reduce pressures on the rest of the system, it's not going to reduce pressures if the ambulance service thinks they've only got usually one option, which is, as you say, convey to A&E. So I think it's understanding, so part of our work is to support the changes and improvements around 111, is one of the key messages is commissioners, please update your directories of services. Part of that is also because the staff who work in CCGs don't always necessarily talk to each other. believe it or not. So that does happen quite a lot. So it's very basic, simple things of linking up the wider developments around urgent and emergency care, as well as the wider developments around urgent and emergency mental health care. So as a linguistic point, we're trying to talk a little bit more about urgent and emergency mental health care to mainstream it. Otherwise, it's kind of, mental health is this thing over here, and it's not really understood that we need to improve the mental health strand in every other bit of urgent and emergency care, be that the ambulance service, be that A&E, be that urgent treatment centres, be that one-on-one, etc. But I think we're going to be able to kind of be very clear about what needs to happen in terms of updating the directory of services. So it's not just about urgent and emergency care either. Really speaking, the directory of services is kind of, it should be the single directory that primary care could even use as well. So I think that is a job that's started, but we've got a fair bit to go, I think.
Just a few questions about service user involvement in the IU. That apply lots of people I thought I'd ask them now. I think you guys work hard on that aspect, so no criticism. One question that was asked was how many and what proportion of attendees today are service users, and do you measure that? Like when you ask people, when people sign up, they.
I'm not sure we've measured it on Eventbrite, have we, Vicky? I mean, we know that we have a core lived experience working group of 14 members,
Sure.
and then a wider network whom we also invited, who are how many, Vicky?
There's 13 people on the group.
Yeah.
And today, 5 people here from the Experience working group, and at least 3 people from the union. So we
Yeah.
weren't doing it.
So we've invited the people who are within our own networks, and then we also publicly advertised the event on Eventbrite, but I don't think that we've measured who came
Sure.
via
Fantastic.
Eventbrite.
I'm really glad that you did the live stream. I would have put out the link for it. It's already sadly really sabotaged by poor Wi-Fi here, so I couldn't. For the next one, do we have that what you think is going to the link is going to be in advance, so I could then kind of put it out to various networks or service users that
I think Andre did actually advertise the live stream address in advance, didn't you?
We could,
I don't know if I did actually, but
Maybe.
I can definitely do that next time. That's
Anyway,
easy.
yeah. It's certainly been up all day, but
I mean, it's no criticism,
sure.
just think about how to move things forward.
yeah. And also it will be available afterwards.
Wonderful.
And so will our questionnaire on what to do next, and so will
And
loads
slides.
of podcasts
Lovely.
that Andre's made through the day, and so will the slides, I think, too. So
Andre is an
it
absolute
should be
star.
possible to sort of...
Come here and say
It
that.
should be, so it should be possible to kind of recreate the experience, plus a bit more from the podcast,
Fantastic.
if somebody sits down tomorrow to engage with it.
Well, Andre's a star, so I think.
Yeah. And he's a collaborator on the policy research unit, so
Absolutely.
we're kind of trying to do
Fantastic.
public engagement. But
I also appreciate the fact that this is free, and that makes it a lot easier for people like myself who are on benefits or whatever. The issue did come up prior to this about if there's someone asked if there could be expenses forms. I appreciate I know you could. I appreciate that you have a limited budget. Is there scope for thinking about how we can manage money so that money that's spent on things that aren't as necessarily, like for example the food there was delicious, but there did appear to be more than was needed, and I would imagine there's a lot of people here today who could have afforded to bring their own food, or if we could divert money towards something to help fund people who are on very limited incomes to be able to come to events as well.
possibly, I mean, I think we'd have a bit of a problem with. I think it's fairly cheap catering. Actually, it's UCL. Fairly basic. There are fancier forms, and I think we'd have a bit of a problem with expecting people to be here all day and not offering them lunch. I think we can look at the exact amount. Not quite as many people turned up as signed up, which is a perennial issue for us with these things. We do oversell them a bit, but even, you know, some of them we kind of almost ask people to write in with their both parents' confirmation that they're really coming, and they still actually don't show up. So that is a bit of a challenge that tends to result in over-catering. We have paid expenses for the people with lived experience in our various networks to come here today, which we were able to do within our budget. Our budget is a bit constrained, but we can look about whether we can offer at least a few places. I think we're never going to be able to offer everyone who wants to. But yeah, it's an issue we can think about, although it's kind of not something we've formally budgeted for beyond our own network, but it's worth reflecting on. Yeah, but we've tried to do these events cheaply. Sometimes we get complaints that it's not very inclusive, that we do it on university premises, for instance, but we do that because it's free and therefore easier for us to make it accessible in other ways, like it is free and it is live streamed and Andre's here and all that. So, yeah. Hi.
Hi.
I'll ask both of you, so what do you
Thank
think?
you. Thanks for an interesting day. I'm going back to the last point on the slide that's still up, and I would like to know, there's a question about whether you the plan is to take this from, you know, an aspiration to something that's practical and concrete and has a framework that will support and resource user and carer-led research. You know, I know the Survivor Research Network is really struggling. It is very little funding, and independent researchers who are service users. I can't speak for carers, but I'm guessing that they might be in the same boat. That research takes a lot of, you know, time and energy and resources, and sort of protecting and resourcing that. I would like to know how it might be kind of taken beyond, you know, an aspirational paper to something that would be useful to the community of researchers who are passionate about doing research from the lived experience, and that can really contribute to learning, because I think many of us want to contribute to the knowledge that we know that's there about what are the alternatives that can divert people from crisis into, or to reduce the need for the use of voluntary detention crisis.
Anybody want to talk about that? Vicky?
So we do, as we were saying earlier, have a lived experience working group, but that has limited ownership, which doesn't answer the query, we understand that. And we're always looking for new ways to involve people. So, as Sonia said earlier, so we have the lived experience working group and the wider lived experience network. And those are our two main organs at the minute to involve people with direct lived experience in our research. However, the doors aren't closed, so we're always looking for new ways to involve people.
Although we're not doing.
My question is broader and more not just focused on here.
I pick up the board point.
Yeah.
I've just tweeted, guys, it's fantastic where I put that on his final slide, and credit to you. And I was sat here thinking, Ensign and others are going to be very pleased to see that statement, but how do we follow it up with meaningful resources? And I just wonder if this needs to be fed into NFIHR.
Yeah.
And
Well,
so
that's one thing we are feeding back to to DH
just
and
to be
NHS
talking about
today.
how do we fund service user-led groups, carer-led groups who do, and also perhaps funding partnerships with university-based researchers that we might more easily work together.
Yeah, I mean, it's a very small thing, but I'm, apart from the Policy Research Unit, I'm leading a national Research Council funded network on loneliness and social isolation and mental health. We have made a commitment in that we're able to fund some small projects through that, which we're not able to do through the policy research unit. We work to what the funders are, the policymakers ask for. But we have funded through that to fund at least 2 service user-led projects. And I think some of the other new collaborative networks in mental health are doing similarly. Sarah Carr's the lead for both that and the policy research unit work, and we'll be able to talk about that.
I wasn't meaning to direct it in any way as criticism of the policy.
No.
Saying that it's
Absolutely,
wider,
but it is
wider.
certainly something we can feed back to the DH and the NHR. Yeah. I think you were first in front.
Yeah, I just had a question about the working groups and kind of how people are recruited and whether or not there's an issue in terms of representation. I'm not sure there's a big solution to that, but I suppose, especially when it's something around the Mental Health Act, there's a lot of people who are in wards and a lot of people who can't go, oh yeah, I'll turn up to this thing, who don't have their voices heard.
I mean, we kind of did our best in that we had a nationally advertised kind of recruitment process led by Sarah Carr, in fact, in which and Vicky, who's our lived experience coordinator, who works to lead on that work among the staff. And we did aim for a sort of representative group and this wider network. We actually hadn't planned to start with, but set up as an additional thing because we got so many really good applications. It's general, it's not purely focused on the Mental Health Act. But we tried to be.
The process of being recruited is quite daunting for a lot of people.
Yeah.
I'm not sure that is going to end up with a group that actually is representative at all, because if you say to a lot of people, oh, you need to do an application, I can't do that.
No.
Now, what about people who can't read and write?
Yeah.
Who already it's just not clear. Yeah, but I just think there's no quick solution, but I think it's something that definitely needs to be looked at, not just here, but in all research and all.
I suppose also it's important that we have this working group, but there in a way about how to engage with the public, that we shouldn't end with our group or our network. But I mean, it's certainly not perfect. I would say that we're trying fairly hard to do some reasonable involvement, but I'm sure, it obviously ends up being far from perfect, really. But hopefully it gets incrementally a bit better as things go on. Yeah.
And on that note, and following on from Ben's thing too, Ben mentioned next time.
Yeah.
Will there be a next time? What happens next? How will this all be collated? Who will make decisions about what happens next? And in terms of the Mental Health Act, things could start moving quite soon once the government gets themselves together.
Well, we haven't
what will happen? We don't want to kind of miss the boat.
Yeah.
And by the time we've decided what's going to happen in terms of research, it's too late to this stage.
Well, one thing in terms of research, I'll ask Richard if he'll say something general. In terms of research, one thing we have been asked to do today is to feed back to Alison Tingle and Ursula Wells, who are the research liaison officers at the Department of Health, to have a conversation with them about whether there are further things that could be done within the policy research unit's envelope, although we are moving on to work on various other policy things, because there are any number of things we could work on. And also we are feeding back to them about commissioned research and making suggestions to them about, what could be done quickly, maybe by the policy research unit, maybe by somebody else, what would need a sort of more substantial research study to be commissioned. So we will go away with notes from all the stuff people have said and feed back to them, and also with this online discussion. Richard, you want to?
Sure. I'll just say 2 things. One, quite general about where we are in responding to the Mental Health Act review from the government perspective. My name is Richard Keller. I work at the Department of Health and Social Care in the mental health team. Essentially where we are at the minute is that the government's received all the recommendations of the independent review and is working out what to do next. We expect the government should be saying some things about that very shortly, in the next few weeks, But as has been mentioned many times today, the next few weeks is a busy time for politicians, so we're having to work in that kind of context. But the government has committed to legislate, it's committed to do a full response to the review, and it's already accepted a couple of the recommendations in principle around advanced decision making and nominated persons in particular. But to use the example of user-led research, the reflections that Viral's got on the board here are built on what was recommended by the review, and so the recommendations around research in the review, we in government will be speaking to folks like the NHR, where the recommendation has said there should be a greater involvement of user-led research and what have you, to think about what are the structural things you can do to enable that. So where all those conversations are going to get to, I can't say at that stage, but that's the process that we'll be going through and working out how to respond to that recommendation on the review. Yes, sorry.
Can you just say that to call it user-led research or to, even call it peer production, you have to ensure that there's that parity of working. So you'd have to have lived experience researchers who are going to feed into the research question and also the methods that choose, the actual research design, and also ensure that if you've got a team of researchers, you want people who are on the equal level, level, and what that having the chief investigators actually co-producing that, because we have professors, we have doctors, done a piece of research recently, and we didn't ask for people certain types of education, but we were looking at lived experiential workers, and what we found was that 70% of people who've got university educated or above went up to postdoctorate. When you looked at what they were earning, 70% were earning 20 grand or less, and some people were earning less than 5 grand or maybe nothing. So at the moment, it's not that actually that mad people aren't clever enough or they're funny. It's actually the ceiling isn't even glass, it's concrete. So you actually need to employ us and to ensure that those posts are available. So it's quite, but we don't have that power to do that. We've got the power to struggle and kind of get there, because it's often twice as hard to get anywhere in academia when you have a mental health issue as well. And I'll say that as a magical researcher myself. But actually, then try and get posts or PhD or fellowships. I mean, even when you look at NIHR, you've got things like the PhDs for allied mental health professionals. Well, they're not even considered allied mental health.
There are some PhDs that you can apply for though, and if you get to know some, I mean, I think you're right. It's difficult, but I'm aware of a number of people who have managed to.
There's so much more. There's so much more in the way for us.
Yeah.
And yet we've got. So I should, but I'm just really trying to put it out there. Because we can try and implement, but you've got to actually open the door and find sense.
Okay.
The points very well made.
Yeah. Okay, great. Stephen, do you want to have the last word?
Very quickly.
Yeah.
Again, it's great to see the reference to user-led research up there. What I was going to say is quite simply, there've been a number of ideas for research that have come from the experience perspective here to there, from Brian Robinson, from Dorothy, and in the Look Experience group. So, I mean, putting some money into researching some of those ideas led by service users would be a kind of great start. Kind of provocative.
Okay, that's a good place to end. All right, thank you very much, everyone.